Okay, Hes, it is now time, so I think we'll begin our webinar for today. So,
Excellent.
dear friends, welcome to the 125th ICC webinar. My name is Junior 2, and I will be moderating today's webinar. We are very honored today to have Professor Percy Rossell-Perry with us for a talk on the cleft nose repair, reducing the burden of care. Professor Rossell-Perry is currently the professor at University of St. Martin de Porres. He is also the current president of South American Medical Advisory Council of Smile Train Foundation. In addition, he was the president of Latin American Craniofacial Surgery Association from 2018 to 2020. He has also written numerous articles and books on cleft surgery. So we're very honored to have Professor Percy Rossell-Perry with us tonight. In addition, we also have three esteemed panelists with us for this webinar. First is Dr. Dax Piscasio from Thousand Philippines Medical Center in Philippines. Second is Dr. Po Chen Huang from National Taiwan University Hospital in Taiwan. And last but not least is Dr. Elke Andana from Dr. Sutomo General Academic Hospital, Airlangga University in Indonesia. So without further ado, let's welcome Professor Percy Russell-Perry. Professor?
Thank you. First of all, I want to thank you for the opportunity to be here and also congratulate you on being chosen to host the next Cleft meeting. Very well deserved. The point that we have today is related to the primary cleft rhinoplasty with focus in reducing the burden of care. I don't have conflict of interest to declare, and these are our lecture goals. First, primary nose repair of unilateral complete forms based on the surgical nasoalveolar molding. The acronym is SNEM and reduce the burden of care concepts. This is the burden of care related to the primary nose repair in unilateral cleft lip nose patients. Our presurgical orthopedics are considered a primary rhinoplasty, also actually primary septoplasty and postoperative nasal conformers. We are evaluating point by point. First of all, presurgical orthopedics and burden of care. We may consider easier surgery, faster surgery, maybe better aesthetic and functional outcomes, better scar, better feeding, or better facial growth. However, there are not enough evidence. Most of the studies are descriptive. Most of them they have presurgical outcomes, not well-designed observational studies, and also including meta-analysis based on observational, not randomized clinical trials. This is the last meta-analysis published regarding the effectiveness of nasoalveolar molding treatment. The study has 1,432 studies from 1946 to 2024. They included 2 randomized clinical trials and 3 controlled clinical trials. One randomized clinical trial was assessed having a high risk of bias, and whereas the other has an unclear risk. All included controlled clinical trials were rated as having a high risk of bias. Conclusions? No conclusions can be drawn on the nasolabial aesthetics, as none of the included studies evaluated this primary outcome in the short or long term. Further, high quality studies are needed, clearly. What about costs? These costs are published, these studies here were published in the United States, and these are the related costs in that country. We may consider that nasal-alveolar molding patients had significantly more made, canceled, no-show, and missed visits, and higher missed percentage than addition patients, indicating a higher burden of care to families. This is the conclusion of these papers. What about complications? Of course, complications exist related to any intervention. Cost of complication treatment and implications in primary and secondary surgery should be very well considered. In this study, these are different complications related to the use of presurgical orthopedics, skin rash, tissue irritation, ulceration, feeding problems, broken appointment, appliance removal, and concluded that 62% of the patients who failed to complete name reported complications as the primary reason they stopped treatment. This is a publication from Bis et al. On an intraoral scanning of neonates and infants with craniofacial disorders, and they concluded that impression taken in vulnerable patients can be potentially life-threatening, with the risk of airway obstruction and aspiration of impression material. Of course, this situation can be improved using the 3D impressions of the appliance, but it's important because the access to this technology of 3D impression is not for all the centers. Rate of failure. Compliance issues were of greater concern, with an estimated incidence of 30% of broken appointments and an estimated incidence of 26% for removal of the nasal molding appliance by the tongue. Finally, at this point, while we don't know rate of nose revision after name plus surgery, we don't have that information, and also parent and patient stress, time and effort dedicated for parental support. Finally, at this point, we may consider that the impact of stress and anxiety generated by multiple procedures applied to a young child cannot be determined. What is currently known is that the stress is associated with numerous health problems. Subjecting a child to additional procedures should be very well, carefully considered by everyone involved. What about primary rhinoplasty? Second point in this presentation. This is my personal philosophy. First of all, comprehensive restoration of form and function, and we are using the surgical nasal-alveolar molding concept, which is reducing the burden of care. We are not using presurgical orthopedics. We are talking about in this presentation about unilateral, limited use of primary sectoplasty, and fewer revisions. This is my personal evolution during the last 30 years. We started performing Macon type associated with nasal-alveolar molding. We used it. I have a discussion with colleagues. They said, but you don't use because you don't have the technology. And this is not true. We use it initially at that time, but we observed that this is not helping us. That is why we decided not to use anymore. But we used it initially around 1996. Then we moved for primary rhinoplasty alone, using first of all BY Potter technique, then moved around 2012 to the BYC, which is the Potter with adding a lateral C plasty, and we named actually SNAN 1.0, surgical nasal-alveolar molding 1.0. Then finally, around 2023, we moved to the last technique we use actually, which is the lateral C plasty, and we named this as SNEM 2.0. This is our protocol regarding unilateral cleft lip nose repair, 3 to 6 months of age, primary scale rhinoplasty using the pool-modified scaloplasty and the cervical nosalveolar molding rhinoplasty. Around 5 years, we are closing the alveolar cleft and we are performing minor revisions. This time is extremely important for our team because we like to get the best outcome as possible before the school. 5 years is a preschool age. In that way, we consider this time is very important because we can do any minor or lip or nose correction in association with the alveolar cleft closer. Then, during mixed dentition period, we are performing the alveolar bone graft, and around 16, 18 years, definitive certoplasty, and probably some lip and nose refinements. We are not including presurgical orthopedics in our protocol for unilateral, the topic we are presenting today. What is the cervical nasoalveolar molding? What is this? Let me explain you. This concept is based on nasal vestibular expansion. We are putting focus on alar cartilage, septum, but I do believe that the point is the lining, is a soft tissue around the cartilage structure. So that we are creating is an expansion of the lining, and this is producing the outcome I am presenting today. So we are creating a vestibular expansion similar to that produced by orthopedic nasal molding, but this is done surgical, okay, and without the need of preoperative treatment. Therefore, is only one intervention. Using the presurgical orthopedics, we are performing two interventions, the orthopedic and the surgery. Should be done always in combination with the orthopedics. So we are reducing the burden of care because we are doing one intervention. It is used in combination with the primary caloplasty in order to produce also an alveolar segment alignment. Let me show you this example. This is a comparison. Look, to the left side, we have orthopedic name. To the right side, we have the surgical name. This is done surgically. This is done by orthopedics, okay? To the top of the slide, we can see to the left, the preoperative view, and here to the right, to the preoperative view. Both of them, similar condition, complete, probably severe forms. And we are creating a similar molding. Look, we expanded, this is the BYC, expanded the vestibule, and we are moving medially the cartilage and creating an elongation of the vestibule in a not in a similar way like NEM. Look, this is NEM, is expanding medially, but there is a problem that the orthopedic is not expanding all the vestibule, and they is expanding medially, and they are creating the lateral web. Look, this is expanded medially, but this is creating a lateral web, which is a common problem associated to the orthopedic plus surgery. So we do believe that the surgical NAM is producing better outcomes because we expand all the vestibule. This is important. What about the alveolar, the maxilla, the upper maxilla? Look, to the left, this is created by orthopedic. To the right, this is created by muscular action. Probably looks like similar, but it's not similar. Look what the orthopedic is done. It's creating a collapse here. Probably this is not well performed. I use photographs from publications. I understand they are the best outcomes. Probably you can do better if you perform NAME, but this is common. Look, this is collapsed. This is not collapsed. I believe that the best orthopedic are the muscles. When you repair the muscles are putting in place both segments in a more physiological way. That is our point. I will show our outcomes today. This is presurgical orthopedic. This is the surgical name done by labial muscles. Look at this example. Look at the severe form of unilateral cleft lip and palate, and look how the maxilla is aligned by muscular action. We didn't use any orthopedics. This is a study published by Okak and et al. In 2024. There was no statistical significant difference in the long-term three-dimensional anthropometric measurements and dental model analysis between named group and non-named group. This is our method, surgical methods, the pulchiloplasty. Basically, this is like Randall, any other triangular method, but I believe that the advantage using pull is the placement of the triangle. We place the triangle in the middle of the philtrum. Why in the middle? Because this is a natural depression. There are two segments in the lip, in the philtrum, nasal philtrum, and there are two segments. This was very well described by Poole, Robert Poole, who was in my country. I met him around 1998, and at that time I didn't understood very well the technique, but during the years I understand better. Look, this is the supralabium, and this is the infralabium. And there is a natural depression and a curvature here, and that is the right position for the triangle. That is the method we use it, and with good outcomes, as I show you. What about primary class rhinoplasty? We have two methods, as I explained. Initially, we use the BYC. This is a BY advancement to put in place the color cartilage, and the lateral C-plasty. That we are doing is an expansion of the nasal vestibule. This is an expansion. This is the publication. This is the technique used initially. Of course, we may have these problems. It is clear. This is a more aggressive technique. That is why I do not recommend for anyone to start performing these techniques without any adequate training, because you may get these complications which are very hard to be corrected. Initially, we have these outcomes: granuloma, 50%, 12% of the scar contractor, and synechias in 6%, which is high for this severe complication. However, these numbers were improved during the time actually, and should be updated to be presented. But it is important to show you what is the risk of using this technique. This is the reason why we move to the next method, to the SNAME 2.0. Reasons to obtain these bad outcomes: bad use of the technique, short experience using the BYC, and this is important, non-use of post-op nasal conformers. Nasal conformers is extremely important to be used in association with the BYC to prevent scar contractors. This is the STEM 2.0. This is only a lateral C-plasty. We were thinking about how to reduce the incisions and the risk of scar contracture. So we moved to the lateral C-plasty, and in the section of the nasal tip, we may put in place all the structures, and we create the expansion of the nasal vestibule. This is the lateral C-plasty. This is the technique. Look, this is a C-plasty. The one branch is in place lateral to the alar cartilage. Then we may create the other flap as a mirror image. You can see here the AB is similar to CD, and the EB is similar to EC. This is an example. This is the alar cartilage here. This is the marginal line, and this is the placement of the C-plasty. At this point, I think this is an important contribution from our experience, that we perform the nose first. Why? Because it's the best time to access all the structure in the nose, because the lip is open. It's easier to access all the structures. So most of the surgeons, they are repairing the nose after lip repair. But it is more difficult because the area is reduced by the lip repair. if we perform the nose first, we have all the structures more accessible. That is, we believe. We have the incisions here, then through the incisions, we do performing the tip dissection, nasal tip dissection. Then the incision at the base are important. This is the C-plasty. And we are performing one incision at the base here, and the other in front of the turbinate. Look, this is the lower turbinate, most anterior portion, and the incision should be placed properly, avoiding any connection with the flap, the lower flap of the C-plasty, most posterior flap of the C-plasty, avoiding any connection because this is creating a disruption of the C-plasty. Should be placed between the C and the turbinate. That is the place for the incision as long as we need only. Then we can do the dissection, and then we are using the transcutaneous stitches to put in place everything. But there is an important sequence. This is the sequence from medial to lateral. If we put the stitches first lateral, we are putting more lateral deposition of the alar cartilage. So we should put first medial stitches and then lateral. First, dome alar cartilage lower border. Second, the upper border of the alar cartilage here. Then interdomal suspension, anterior and posterior. Then alar cartilage lateral border, and then the C-plasty, and finally nasal vestibular lateral wall here. That is the sequence. Muscular repair is extremely important. We have sent for publication and study regarding the muscles, and there are important muscles not well considered in the literature: the myrtiformis, the alar portion of nasalis muscle, and the presurgical muscle. They are connected naturally. In normal people, they are connected, and we should connect them, providing support for the anterior nasal floor. Let me show you, this is an important anatomical structure. Let me show you here, please. Look, this is the lip incision, cleft margin. We are separating the skin from the muscle, and look at what is the structure which is appearing here. Look, here, there, at the top here, there. Look, this is an important structure because it's a tendon. This tendon let us include all these muscles to be repaired. If we cut below the tendon, we are not including the nasalis muscle at the portion, and probably we are leaving part of the myrtiformis muscle. So we are not creating a functional repair. Remember, the nose is not like a tube, it's a valve. There are two valves in the nose, and this is a functional structure, and the muscles are extremely important to be repaired to obtain cosmetic and functional outcome. Excuse me? There. Look, this muscle repair is functionally, and also we are bringing support to the anterior nasal floor, because the nasal floor has 4 sections, and we are bringing support for the anterior portion, and we don't need the alveolar bone graft to support the ala, which is misconception, because we used to consider that we need the alveolar bone graft to put in place the alar base. This is not true. This can be done by muscular repair. Look at this. Look. This is a severe form. Look at the position of the ala. Look at the position of the columnar base and the premaxilla here. And look, we can correct perfectly the position of the ala only by muscle repair. But we should include proper muscles, as I mentioned it. We should identify where the muscles are, and we have to include all of them. What about the nasal conformer? Another point in our burden of care analysis. First, we use in our practice custom-made acrylic stents, because silicone stents, I understand they are better, but because of the cost of the silicone stents, we decided to use these custom-made acrylic stents, and they are maintained using tapes and applied 1 week after surgery, not immediately. These devices have a perforated extension into the nose that keeps the airway clear and prevents scar retractions. Okay? Due to the patient tolerance, the conformers were recommended to be used at least during 8 hours daily and during 6 months post-op. Look, this is our acrylic stents we made. We have to take impressions and we use a personalized design, personalized stent to be used, and patients tolerate well, as you can see in this picture, using tapes to fix the appliance. This is a study, a systematic review and meta-analysis 2025 about post-op nasal conformers. And in this study, they observed nostril width was wider on the cleft side and nostril height was lower on the cleft side. Probably this is because of the limitation of the surgical technique, I believe. And the main bias, comparison between patients operated by different surgeons in this study using different surgical techniques. Then they concluded further research, including randomized controlled trials and longer-term follow-up studies, are needed. We did a study also. This is a systematic review. We did a comparative study between a group of patients without conforming and other using conformers. And our comparative study did not find any statistical significant difference regarding percentile indexes of nasal asymmetry between groups. Therefore, the conformers are not improving. They are not improving the surgical outcome. However, we consider that they are preventing scar contracture because we are using intranasal incisions, as I show you, at the nasal vestibule, so it is important to prevent any retraction and complications, as I show you. What about the systematic review? Based on these findings and available scientific evidence, definitive conclusions about the effectiveness of these devices on nasal symmetry cannot be drawn. What we don't know about post-op nasal conformers? We don't know post-op nasal conformer rate of failure in association with surgery, rate of secondary surgeries using post-op stents plus surgery, and associated stress. This information is not available, and probably this is increasing the burden of care. What about our technique? We published studies about the effectiveness of the surgical method we use at the presurgical age using the BYC, published in 2020. We observed a statistical significant difference between pre- and postoperative columellar angles and alveolar cleft width, and no statistical significant difference between nostril down heights, alar base position, columellar length, lip and vermilion heights at the age of 1 and 5 years. Second study during mixed dentition period age, around 8.2 years, total nostril symmetry have been observed in 34% of patients at 7 years or more of follow-up, and major revision requirement, which means more than 3 millimeters of asymmetry, observed in 9.3% of patients. This is the scale. Look, grade 1, total symmetry, 34%. Grade 2, asymmetry around 1 to 3 millimeters. And grade 3, more than 3 millimeters. This is the outcome observed, 9% in grade 3 and 34% in grade 1. Look, outcomes, SNANE 1.0, 1 year of post-op. Look at the nostril symmetry, only achieved by surgical technique, not using presurgical orthopedics. Look at the outcome between both sides. Look at their severe cases. Look at these 2 years, the nose, using one intervention, one surgical technique. Look at this nose, the nostril symmetry obtained after one intervention. the BYC. This is the BYC outcomes, 1 year, 5 years to follow up. You can see the comparison between both sides. We didn't use any primary septoplasty at this point. It's only done by nasal tip. Sorry. Look at the alignment of the segments. Look, without any plate. We don't need plates to put in position the maxillary arc. This can be done by muscular action. 5 years old. Look at the maxilla. It's aligned. Look at another case. Look at this. This is the point. We consider that the presurgical orthopedics is an alternative. This is not the gold standard. This is promoted by different centers as gold standard. This is not the gold standard. It's an alternative. If you like it, you can use it. But you can do this in one intervention using an adequate surgical technique. It is possible. Also, we didn't use any primary septoplasty. Look at the position of the columella. It is corrected, and the nose symmetry can be achieved without any primary septoplasty. However, I understand that probably selected cases may be a good indication for primary septoplasty, but not for all cases, as some authors are promoting that even incomplete cleft lips should be considered the primary septoplasty. I don't agree about that. Look, 5 years. The outcome is maintained during the time. I don't have 18 years old follow-up, but we are in the process of recording information to get that information in the future. But I have 10, 12 years, 5 years follow-up, and the outcomes are maintained. Another misconception regarding primary cleft rhinoplasty is that always the nose is coming down. This is not correct. This is not, and I don't agree about that. I think if it is relapsing, it's because of a limitation of the surgical technique. Look, 5 years, the maxillary arc is aligned without any plate. Another case, 1 year, 8 years. Look at the nose, 8 years, and the maxillary arch, corrected by physiologically by muscular action. Look, minor difference. This can be grade 2, minor difference between the nostrils. Look, 10 years and 12 years. This is the BYC. What about the new technique, SNEM? This is a more conservative. I understand that this is also aggressive, but this is less aggressive than BYC. But when we decide to move to this more aggressive form of primary rhinoplasty, because of the outcomes, you can see the outcomes. We didn't achieve that quality of outcomes using a more conservative treatment. This is in our hands. Probably you can do that. But we moved to a more aggressive form because we understand we have to correct more. And I understand that the problem is the lining. So we have to lengthen the lengthening. Because when you observe the outcome after NEM, the nose is corrected because the NEM is expanding the vestibule. Then I understood that the expansion is necessary to put in place the structures. So I think that we can do the same surgically. We can expand the vestibule, and we can do the same as NAM is doing, but this is in one shot. The problem with the NAM is the surgical technique, because after NAM, we have to use a surgical technique to correct the nose. And probably the surgical technique is limited because it's more conservative. And that could be the explanation, the reason why there is a relapse. That could be the reason. This is a study published recently about our initial experience, and we can see 75% of total nostril symmetry, 1 year or more of follow-up, and grade 3 in 8%. Look, look at the cases. 1 year of follow-up. Look at the symmetry of the nostrils here. You can see better. Look at this is the pool. Look, this is not a good photograph, but you can see how the filtrum is repaired, and there is a natural curve in the nasal filtrum here. And this is provided by pool using the triangle in the middle. This is the important difference with other triangular methods. And you can see we didn't any primary septoplasty here. Look, same patient, 1 year. Look at the symmetry of the nostril in one intervention, reducing the burden of care. Excuse me, reducing the burden of care. Same patient, 2 years follow-up. Look, 2 years of follow-up. Same patient, another one, 3 years. Same deformity, severe deformity. Look at the position of the ala here. Look, look. Probably not perfect, but minor difference. Another case, 3 years old. Look at the nostrils. Discussion. How can we estimate the outcomes? It is important. Close to 100% of global population, have some degree of facial asymmetry. And 80% of global population have some degree of septal deviation. Then around 60% of population have a self-perception of the facial asymmetry. Not all the people. Some people, they don't have a self-perception of asymmetry, but they have, because this is natural. This is the publication, and based in these considerations, probably more than 90% of the patients in this study presented today could be considered as normal noses. One more comment. Look at this nose. This is not perfect symmetry. There are not perfect symmetry. The nostril here is different than this. There is a small difference here in height, and also the width is different. What about this? How can you estimate this outcome? Well, this is my nose, but this is a normal nose. So we should not achieve perfect symmetry of the nostril. Probably minor differences can be very well accepted. In that way, our outcomes, I do believe that they are good outcomes to be considered, in special in the concept of reducing of burden of care. I'd like to discuss a little more about other options that they are actually used more. Look, this is what about the GEMA overcorrection, and sometimes skin resection. This is a method widely used actually, however, may be associated with persistent overcorrection. Not only the height, the nostril height, also nostril width. I have seen. And lateral web development, since it is difficult to predict wound healing. We cannot predict wound healing. Okay, can be done based in our experience. Probably you may have a success if you have experience to know how much overcorrect, but we cannot predict wound healing. Another concern about the GEMA method is the functional impact over the external nasal valve. Remember, the nose is not a tube, it's a bulb. It's functionally. And if we affect functional areas, this may affect nasal physiology. Look, I use from this publication, these pictures, you can see here the overcorrection, and look at the outcome here. Look, this is I understand that the pictures in publications are the best outcomes. That I understand that, okay? That is the reason why I use it. But look here. This is still overcorrected. This is the left side is the cleft side. Look, this is normal, and this is still overcorrected. This is more difficult to be corrected than undercorrection. Undercorrection is very common, but it is easily to correct than this. Probably here we need a composite graph to correct it. Okay? And also, not only the overcorrection, look, lateral web here. And probably this is affecting the nasal physiology, the nasal function. because this is closing the airway. Also, I will show you here, this is an important area because the soft triangle is a component of the external nasal valve. This is a study, and they conclude neglecting the soft triangle area might yield grim results in terms of cosmetic and functional aspect. The Tajima incision is affecting the soft triangle because it's moving downward inside, and that this is then the soft triangle disappears. There's not soft triangle here. Soft triangle should be here, and here there's no soft triangle. So the impact of this method, very well-known method, on nasal physiology is not measured actually. Should be done. Because we accept, okay, cosmetic is acceptable, it's better. Okay, probably it's better, but what about functionally? It is important, okay? Discussion, what about primary septoplasty? Another trend. Actually, I am surprised, let me tell you this. Publications, some authors, they said we should do primary septoplasty in all unilateral cleft lip, even including incomplete forms. I am surprised, totally surprised, because you can see the outcomes. We don't need the primary septoplasty. This is not functional repair. The primary septoplasty is only cosmetic because we are correcting the position of the columella, as I understand. But this is limited to the caudal septum, and absence of adequate evidence exists. There's no evidence. This is a publication from Tse et al. In 2019 about the foundation-based approach using primary septoplasty, but this is level 4 therapeutical clinical questions. This is a low level of evidence. There are no comparative studies. There are no, of course, there are no clinical trials. I understand that. But we don't have enough evidence to consider the primary septoplasty as a treatment for all cases. Let me show you this. Probably this can be a good indication. Probably. Proper indication for primary septoplasty is required. It is not suitable for all places. Look at this case. It's interesting. Nostrils are improved very much, but look, we can see here the caudal septum, and look at the position, the columella is not well corrected. Probably because this is a good indication for primary septoplasty. And of course, I am performing this procedure for selected cases, but we need more information, which are the good indications for this procedure. But in our understanding, after 30 years performing cleft repair, it is not for all cases. In summary, we are not using presurgical orthopedics in unilateral cleft lip palate. It is not helping. It's an alternative. If you like, you may use, but this is not the gold standard. It is clear. You can see the outcomes. We can have good outcomes without presurgical orthopedics, and we are reducing the burden of care. Primary rhinoplasty, of course, we have to do that. It is well accepted. Primary septoplasty, not for all cases, and better studies required. And finally, the use of postoperative nasal conformers should be preventive of synechnias and scar contracture, but it is important. It is not improving the surgical outcome. What you are doing in the surgery, it is deciding the outcome. It's not the conformer. Because this is another misunderstanding, because we are not correcting well the nose, and then we use a conformer to improve the surgery. It is not true. The conformer is not improving the surgery. It's only preventing the scar contracture. It is very important. In that way, I am using, because I am using intranasal incisions. As I show you, we may have a synechnia. This is a severe complication, difficult to be corrected. So I recommend in all patients, they should use to prevent scar contracture. This is a comparison between traditional NAM and the surgical NIM. A limitation, NIM is always required in surgery. And the limitation for the surgical NIM is a more aggressive rhinoplasty. I understand totally. If you don't have experience, please don't do this. Can be a disaster. This is important because patient is first, okay? If you have a training, if you me understand better how is this working, and you are taking any prevention, and you're using conformers, and the patient is using the conformer during the time, okay, you can do that, but take care about that, please. I don't want to say this is an excellent method. No. Any intervention has limitations. Any intervention has complications. So we should be very careful about to perform these aggressive forms. Cost, of course, there is a cost for orthopedics and also for surgery. In this case, it's only surgical cost. Intervention, presurgical and surgical, two interventions. Here, one intervention. Requirement, high parental compliance and orthodontist and efficient surgery. Sometimes, one situation, this is interesting for me, probably 70-80% of name publications are pre-surgical outcomes. This is incomplete. Yeah, because patient is not repaired. And they are showing, okay, it's improving. Now it's improved. Sure, it's improving. But this is not the final outcome because this is this is a kind of expansion. And any expansion, you can see that with expanders using for burns or any other problem. You can use the expander. If you retire the expander, then the skin is returning to the position after time. So it's the same. During the first publications using NAME, they observed the relapse of the deformity when they used the NAME alone. That is why anyone, any center, use a combining procedure, NAME plus surgery, because NAME is not producing any long-term effect. NAME needs surgery. Of course, it depends on the surgical technique, in fact. So this is why I don't believe that there is no room, there is no place for us, in our experience, for presurgical orthopedics. That is why. This is a big discussion. I received comments, and including bad comments during the meetings. But I love discussion because this is science and this is nothing personal, please. This is nothing personal. And surgical NAM, skilled require a skilled surgeon and good post-op care. It is important. The post-op nasal stents and the surgeon trained, surgeon who knows very well the method. It is important. And the goal, the name is reducing cleft gap before the real surgery, but depends of surgery. And the surgical name correct the deformity during the real surgery. In summary, finally, currently, there is no evidence as to which method of primary nasal surgery is the best. There is no evidence. This is not the best method. Maybe in my hands, probably. Okay? Therefore, the burden of care may help us to take the best decision. It is important. Okay? Proposed techniques here for primary cleft lung repair are effective in obtaining nostril symmetry, measured in the long term until the mixed detection period based in our studies. Low rates of major nasal revisions have been observed during the follow-up time, and of course, we need more studies. Here we have, these are my publications to sharing for you, publishing in Spanish, in English, and also in German language are published. And finally, all the contents in our last textbooks about primary cleft rhinoplasty for you, for your critics and your comments. Thank you very much for the opportunity to be here.
Thank you so much, Professor Russell, on this amazing webinar. And also thank you for sharing with us your detailed explanation of your methods. So now at this time, I'd like to invite our panelists for some panel discussion. And the first panelist that I'd like to invite is Dr. Dax Picasso. Dr. Dax?
Hi. Hi. Yeah, can you guys hear me?
Yes.
Yeah. So
Yes.
first of all, thank you so much, Professor Russell, for that discussion. And I agree, it's going to be a very interesting discussion because uh, we're trying to compare like different techniques here. And what I'm trying to understand is I'm a bit confused on why we're trying to differentiate the NAM and the surgery, because for me it's like two different things. Like from how I understand it, we're using the nasoalveolar molding because we're trying to take advantage of that period where the maternal estrogen is still high in the circulation, so the tissues are more moldable. That's why we're trying to just bring the arches together and try to mold the nose, so that at least when we get to do the surgery, it would be a lot easier, or they'd be in the correct position already. But I do get your point, because with or without the NAM, we're still really going to do the surgery. It's just that when you say that it's a surgical NAM, so basically when you say you're doing a surgical NAM, you're doing the primary rhinoplasty, right? And then it should take the place of the NAM if ever we did not do it, correct? Because well, to be honest, I would have wanted my patients, our patients here, to be on NAM, but when we get them, they're already beyond that period where we can apply the NAM. So really you have to just go on with the surgery. So
Right.
that's one of the clarifications that I want
Right.
to ask. And the second is, I noticed that you have excellent results, no doubt about it. The results are excellent. But when they check the height of the nostril, I think they're looking for the highest point of the nostril, right? But when you notice, if we're not going to tinker with the soft triangle, what happens is the soft triangle on the cleft side is always a bit lower. And I do agree, like in personally in my practice, I do the Tajima, I do overcorrect. And there are some patients where the overcorrection can persist, but actually they're a very small percentage of patients. We do, so normally it happens when we overcorrect too much, but when we overcorrect for just about 1 to 2 millimeters higher and narrower, it normally stays in that position, or almost symmetrical to the other side. And about the nasoconformer, what do you think about using the nasoconformers that are also overcorrected? Because that's also how we use the nasoconformer. Of course, we're using the silicone ones that are also overcorrected on the cleft side.
Okay. Well, there are many questions. Let me
I'm
try
sorry.
to answer. No, excellent. Thank you. Okay. First of all, I've been looking the name. There are different orthopedics, right? Different methods. I like to say name to be easier to talk about. And and when I've seen the outcomes, we use it initially during our first years. The nose is corrected because the nostril is in position, because you can mold. You're molding the nose using the stent, and you can put in position everything. Oh, this is excellent. This is magical. Okay? But this is not long-term effect, of course. So then I understand that we can put in place creating an expansion of that area, because the stent is expanding. Is that it is doing, it's creating an expansion. It's putting in place, but it is expanding by action of the stent. So I decided, okay, we can do the same, but in one shot, surgically. What we can do is to lengthen in. So in that way, I decided to use the name of surgical nasoalveolar molding, because we are molding the nose surgically. And also nasoalveolar, because we are molding the maxilla, we are molding the maxillary arch by muscular action, in our consideration better than the plate. But okay, this is a discussion what you think and I think, but we need science, okay? We need comparative studies to get an answer, of course. This is not what I think, what I believe. This is not a coffee conversation. We should go to the science to decide, okay? Different experience, going to the second question, different experience, okay? I accept that good outcomes with using different methods. My point in this presentation is the burden of care. That's my point. I can do very well the nose. You can do very well the nose. But what about the burden of care? That is the point. If you are performing primary cervicoplasty in all cases, of if you need the presurgical orthopedics in cases like I presented today, so this is increasing the burden of care. This is probably the difference. But as you can see the outcomes, This can be done surgically in one shot. That's the point. It's difficult to get a point between that you are doing performing Tajima and that I'm doing performing the surgical name, because this should be compared and compared based in different variables. In example, complications. You can say, okay, your technique is more aggressive. Of course, it's more aggressive. You may have more complication. Of course, totally. We should consider the learning curve. We should consider the postoperative management. In that point, your proposition can be better because you are less aggressive. You need the support of orthopedics or other or maybe primary cytoplasty. But I think we have to scientifically compare propositions. If not, another point is, okay, you have 30 years doing Cleft. And let me tell you something else. I am dedicated only to do Cleft lip and palate. I am plastic surgeon. I'm not doing cosmetic. I'm not doing burns. No. My life is dedicated only to Cleft lip and palate. This is very difficult situation. I understand. I don't know another surgeon performing only Cleft lip and palate. I am very busy also. Many patient primary, secondary cases, a lot of. So probably this is another consideration because I am a skilled surgeon in this field. And probably this experience explains the outcomes also. So we should go to the science. We should go to the studies to take decisions. That's my point. And the post-op, of course, it is. I presented the protocol. It is if you do something inside the nose, you are performing incisions. It's strongly recommended that you may use postoperative conformers. Extremely.
Yeah, thank you.
Thank you. Thank you for coming.
All right. Thank you, Dax. Next up, I'd like to invite Dr. Bolton Huang. Dr. Huang?
Yeah, thank you, Rossell-Perry's wonderful speech. Yeah, your speech is very clear to explain your philosophy of the treatment by the unilateral cleft lip. Yeah, maybe in Taiwan we are very lucky. The cost of the name is very low. It's very cheap, and the family will be more cooperated with the surgeon to take care more carefully to the children, like the name use fixation and the lip taping. Yeah, I saw your presentation. Mm, what do you think about the lip taping? Is it really effect to the shortening the gap of the lip and easier to repair the lip? Because I think your long-term follow-up, the scar is very beautiful. I'm very wondering about if we don't to use some force to more closely, maybe the natural philosophy, the scar will be widened. This may be to effect about the aesthetic. What is your opinion? Yeah, this is the question one.
Thank you, doctor, for your comment. Very interesting question. Initially, we have a concern regarding the cleft width. Some cases are very wide. Oh, what is this? And initially, I remember that case with lip descents in example, but this is 30 years ago. Actually, I don't have anyone, not single case, no, zero scar problems, and this, of course, descents, different degrees of cleft width. I think the lip taping is acting over soft tissues. I think we can move the soft tissues free from the maxilla to reduce almost all tension. So in our experience, when we are using the tape, patients are coming with some irritation and some problems at the skin. So it is not good when you are performing a surgery. Should be healthy to do that very well. So I think the point is to perform a proper dissection of the lateral segment is a good one point. Second, I used to 50 absorbable sutures to be placed at the point of highest tension, which is in the upper part here. This is the most tensional point here in the closer. So at the base of the node inside, we are using file in the skin and inside PDS and also another point, very important point, is the muscle repair, because when the muscle repair is done properly, this is supporting the base of the nose and also reducing the tension at the skin level. But it is not the orbicularis. The nasalis, there is an extension of the nasalis. This is not described. I have written a recent paper about that. It's an excellent one, with describing the nasalis. And there is a branch of a fascicle from the nasalis, which is coming round and taking action with the depressor septi. So all this is also myrtiformis. So all these structures are are having the tension of the closer and leaving the skin with more relaxed, so without tension. And finally, the third point that I like to recommend in this situation is to use. I like to use the fast absorbing sutures.
Mm.
Fast absorbing. It's
Okay.
chromic.
Mm.
Yeah, it's chromic, catgut chromic, fast absorbing.
Mm-hmm.
Because any other suture is leaving a scar. That my problem is when I don't have that suture, because
Mm-hmm.
I have the lines from the stitches. It's
Mm-hmm.
terrible. It's very sad. But
Mm-hmm.
the problem is that suture is not available in my country. I have to bring from outside. And sometimes I don't have. I have to use Vicryl 8070, but this is removing by itself, but taking more time. So it's leaving a scar. So that is the main problem. But I recommend that the closest should be done the fast absorbing chromic. This is a good because this is removing by itself in a short time.
Mm-hmm.
In that way, I don't need any plate to put in position, any tape, because we can do that surgically, and you can see the outcomes in the lip are good. I haven't seen any hypertrophic scar or something related to the tension.
Mm-hmm.
I think that's the point, doctor. That's my point.
Okay. Thank you for your explanation. Yeah. The second question, you mentioned about the Tajima surgical method is maybe to destroy the shape about the soft triangle, like the nostril, maybe a little asymmetry. Yeah, and the skin will be lost. Maybe the function of the valve will be destroyed. Yeah, this is your experience and opinion. Yeah, but I think you only to use the Z-plasty and the septal suture. It's not enough to restrict the shape of the nose because the conformer is only the inside. I didn't see the outside like to some compression or some fixation to fix the shape of the nostril. Yeah, what's your opinion about the outside uh conformer?
Yeah, perfect. Well, this is not scientifically evidence to talk about that because I don't use that kind of support outside. Okay, it's just my opinion. Uh, I have learned during all these 30 years that we can get the outcome, good outcome, in an easier way. Which is the easier way? Is to use less interventions. That is our concept. If I have less interventions to get the outcome that I want, in our understanding, that is the best way. In any interventions, cost, complication, any stress, anyone, parental stress, patient stress, or any intervention, it is not easy to put in place something inside the nose, let me tell you. I did it. I decided to put a hook here, a hook, because, there are hooks. It's 1 hour, not more, not any more time. It's painful. I don't know how much is the suffering of patient. Okay, patient is looking happy, but during the time, this is not, we don't have that information. In that way, our concept is to use less interventions to get the outcome. If my outcome is not good, probably I have to do more. That's my point. So you can do maybe also in my hands. This is working in my hands, but any experience is different. Your experience is beautiful. I have learned from Chang University. I am I appreciate too much that all lessons I learned from professors, from Tolo, from Dr. Chen, for all of you. I've been in the meeting every 2 years in Chang'an. Thank you to Smile Train, because Smile Train bring me to your place to learn, and I was there during each 2 years from 2004, I think. So I appreciate too much that you do, because you're doing a great job teaching, training surgeons. I love that. Okay, and I appreciate that, and also I understand that you are doing great also. But there are different ways. Okay, I cannot say that my way is the best. No, because this is not compared. This is not scientifically based evidence. It's just my opinion, but this is not compared. We need more information to have that answer. We don't have that answer. It's just my experience. You can do that. If I can do, you can do. It's clear. Okay. I am a normal person. So you can do the same, of course, even better. Okay, that's the point. We are showing what we also in Brazil, also in India, Pakistan, every country, they are doing great. I don't want to say you are, I about Tajima, honestly, that's my point. I presented. I think there are things that it is I don't have clear probably in my mind. That is why I decide I use it. But the problem is I observed overcorrection, and it is more difficult to be corrected. Not only the soft triangle, also overcorrection of the alar base is still overcorrected. I have to. So in my hand, it's more easy to correct an undercorrection. It's more easy. That you can move easily here, or it's than an overcorrection. That's why this is not the best way, but it's just my opinion. It's just my opinion. We need more science.
Okay, thank you for your kind response, and I already buy your books. Yeah, it's very wonderful. Thank you.
Thank you. Thank you for kind words. Thank you very much.
Thank you, Dr. Huang. Next, I'd like to invite Dr. Elke and Dana for some comments.
Yeah, thank you very much. It's very amazing result that you have, Professor Rossell. I can be more agree for your theory about we don't need any presurgical NAM presurgical treatment, because in Indonesia we rarely use the presurgical NAM because it's quite expensive here. It's like about $100 US, and you have to use it for 6 times. It means you have to times by 6. It means $600. But I think I also agree with Professor Dex said that when we back into our basic knowledge about the why we have to molding the alveolar and the nasal very early from the patient is getting in getting birth until we do the lip surgery. I think at the time, the bone it will molding very easily. But uh, your theory is said that you don't need any pre-surgical NAM. We now you use the surgical NAM, which is you do it maybe around 3 months when you repair the lip, right? So I think uh, for us the young surgeon, I think we have to know the purpose of the pre-surgical NAM first, because as I know, the presurgical name it used m- uh, to make the surgeon do the surgery is easier because it will make the gap more narrow, right? So my conclusion is I think maybe for us for the new surgeon, for the young surgeon, maybe the surgical name is pre-surgical name is important. So I want to ask about your uh, nasal conformer, Professor Russell, because you said that you use acrylic for the nasal conformer, right? So as we know that the acrylic is the hard material, and you use it for 1 week, right? Is there any complication like pressure wound when you use the acrylic for the such young baby?
Excellent question. Thank you very much. This is the reason why I like the discussion. Right. This is this is not soft material as the silicon. Silicon is the best. This is clear. The problem is the access to get the because this should be personalized. This is not something that you are buying in a store and putting in place. No, should be personalized because should be measured in basically in the anatomy of the patient. That is why we provide a custom made acrylic, and sometimes it happens when it is not well designed. In that way, patient needs different appointments with the person who was developing the device. Okay, sometimes they should correct and correct because sometimes they are creating local problem. I haven't seen any severe complication like an ulcer. I haven't seen. However, ulcers and cuts and bleeding are described in the literature related to the name. So, in that way, any type of device placed in this area may create problem. It is clear. That is why we reduce the use of these devices to the post-op time only. This is clear. Okay? And we should be in connection with the patient. Any problem should be commented to be corrected. But we haven't seen at this time any severe problem. Sometimes local problems, sometimes irritation or because of bad position of the stents, but this can be corrected. Corrected. It is the word we have seen about the post-op stents. Good. Thank you for the question. Very good one.
Okay, thank you very much,
Thank you.
Professor Russell. It's very good
Thank you.
presentation.
Thank you for your participation. Thank you.
Thank you, Dr. Andana. And last, I'd like to invite Professor Lowe for some comments.
Hi, Dr. Percy.
Hi. Hello, friend.
It's
How are you doing?
it's a long time no see, and
Yeah,
very
we
happy
have
that
seen
you
in
present the
Japan.
topic. And
Yeah.
I must admire your efforts that you. Well, I actually read your paper a lot before. Okay, so I understand what you're doing, and I can see that you continue to improve, to modify, and from today's presentation, I can see that your result actually to me is excellent, very good. So there are some comment and question. I think for the audience, a very important thing is the primary rhinoplasty, and I'm happy to see that more and more surgeons are doing primary rhinoplasty in order to improve the result, in order to reduce the further intermediate rhinoplasty. Now, how to do a good primary rhinoplasty? There are several techniques that you mentioned. You do your Z-plasty, intranasal Z-plasty, and some people do VY advancement, and we do Tajima. And because I do Tajima, because I feel that Tajima is an easy procedure and it's easy to teach my young surgeons. So that's why I use Tajima, and I feel that I can obtain consistent and very long-term stability. So this is my use of the Tajima. And your comment about septoplasty, and I also agree that that septoplasty is up to surgeon's preference. You don't do septoplasty, and I don't do septoplasty. Other surgeons do septoplasty, and if they do septoplasty and then they have good result, I think it's fine. And at long term, they do not find adverse effect. I think that is good. And I also like to agree with you that muscle function is important. Okay. Let's talk about the pre-op NAM. For patients with very wide cleft, I still prefer NAM in order to narrow the nasoalveolar segment, in order to improve the nasal shape. So the surgery is easy, but I do not want to wait for the approximation of the alveolar segment, because I know even now you have 5 millimeter of separation of the alveolar segment, we can easily do muscle repair, and the muscle will do its work to narrow the segment. But if the segment is 15 millimeter, 12 millimeter, then you have to mobilize the muscle a lot. And that, for me, I have checked my previous paper that still the nasal width is still too much. So that's why for the very wide alveolar segment, I still prefer to do NAM. So certainly you have different kind of technique to do NAM. I think that's also fine. Okay, let's discuss some important issue. Lateral web. You mentioned that in our technique, I do not like to address the intranasal web, because in my patient, this is inside the nose. You do not see it from outside. And my patient do not complain airway obstruction. Okay, the nasal web, to me, is surgeons look at it, surgeons do not feel comfortable. So I would like to ask you, in your patient, do your patient complain nasal airway obstruction if there is a nasal webbing?
Well, this is patient probably is not reporting because they are very young.
Okay.
And oh, sure. But the problem of the airway should be understood in different ways, because it's not only lateral web, it's also the septum, it's also the turbinate, it's also the way that you repair the muscles, because the pressor septi, myrtiformis, nasalis. So this is something very dynamic. So we cannot evaluate an airway problem only based in lateral web. I think it's a part of a different problem, and also this should be personalized. So it's difficult to answer your question, but that my point is just, that look at this point, different methods. We can achieve good outcomes. You are doing, That's the point, no? But we need more evidence to get more answers, because there are many questions we don't have answers.
Okay. That is the kind of philosophy that if you wish to do or not to do, deal with the nasal web. But if my patient tell me or my parent tell me that this nasal webbing cause some functional issue, then I definitely will address the nasal web. So this is an issue that is up to debate. Okay, these different surgeons have different idea. Now, another question I would like to ask you is that you mentioned that in your protocol, you do a very nice lip and nose revision, and I noticed that you have a long-term good stable result. But you mentioned that at age of 5 years, you could do some minor nose revision. What kind of minor nose revision are you doing?
Excellent question. First of all, any secondary revision needs experience, because any secondary revision is individualized. Each case is different. The way that the scar contractor, the way that the alar cartilage is coming down, is different. And this is the reason why we need experience. That I like to use is, sometimes if there is a scar retraction, release the scar retraction. If this is one point. I am doing a rotation of the alar cartilage, a composite flap, to move it medially and trying to correct the lateral scar. This is a way that I'm doing. Another way, more simple, is to create a resection. When you are performing tajima, sometimes, not always, you are removing a minor portion of skin, as I have written in your papers. So I'm doing the same, but not outside the nose. I'm doing the same inside the nose, at the level of the marginal level, which is the lower border of the alar cartilage. At that level, I am performing a minor skin incision to put in level the nostril. This is published. Probably I will share with the paper. But you can see vestibular skin margin incision. I have published that method. It's easier, removing the skin from inside, not from outside. And when the difference is minor, can be an option, but should be individualized, of course.
Yeah, Dr. Percy, I like you, would like to thank you very much that you're very dedicated to do Cleft surgery in your country that help the patient a lot, and your result is very good. Now, I want to mention one thing that probably other listeners do not pay attention, is that your result of the alar base is very nice, okay? Especially the Cleft side alar base. And I noticed that for the complete unilateral cleft, the alar base cleft side is depressed. Then to elevate the alar base symmetric to the non-cleft side is very important, and you can achieve that.
Sure.
This is not common. This is not easy, because I pay attention that in many presentations, I noticed the alar base is still depressed. Now, maybe you would like to tell the listener how you achieve the alar base symmetry.
Excellent comment and question. Right. I have even today, when I'm moving for meetings, I'm hearing that the conference is saying we cannot correct the alar base until the alveolar bone graft, because they understand that the alveolar bone graft is providing the support. And this is a misconception. I believe that during a long time. Oh, this is not perfect. Oh, because we don't have a alveolar bone graft. But this is not true. As you can see in pictures, the muscular support is extremely important, but we should use the proper the muscles, because there is not a single muscle. There are many muscles. There is a myrtiformis system here, including the nasalis, myrtiformis, and depressor septi. The role of the depressor septi in cleft lip and palate is not well described. But we understand that normally, both muscles are connected to the depressor septi. So we understand that we should do that in the unilateral cleft lip repair. We should connect these muscles. In that way, it's important to include all these muscles. That is why the tendon I presented and we sent for publication, we did an histological and anatomical study of the tendon, because when you identify the tendon, you are sure that all muscles are there. A common problem is when you lift the tendon up and you are cutting and you are leaving the muscles not connected. So this is probably a reason that you cannot achieve the proper level of the ALA. So also, I understand your point regarding the orthopedics and the width of the cleft. In my hand, there's no difference. 20, 15, 5 millimeters is the same. I can do that because I am an experienced surgeon. Probably that's the reason. Okay, probably not for all, but can be achieved. Can be achieved without a plate. We can do that. Release. We have to release more lateral segment, of course. We have to do more to release and close it without tension, moving the muscles in proper position. But there are many papers about muscle repair, muscles involved in cleft lip and palate, but I think we have to consider in a more dynamic, more fast physiological form the nasal repair. It's not cosmetic only. This is functionally and dynamic. In that way, I think the muscles are the important support to put in position the alar base. Right. Good comment,
Yeah.
doctor. Thank you.
I think it's very important that I especially like your comment that that the piriform margin should be brought into the same level in order to have a symmetric alar base. This is a misconception, because from the beginning, the cleft side piriform margin is already depressed than the non-cleft side, and we even follow up the patient 20 years later. The piriform margin still more depressed, more posterior than the non-cleft side. But what we can also achieve a symmetric nasal alar base because we use soft tissue. Very important concept is to achieve functioning muscle repair so that they can support the alar base in the same level. This is very important concept.
Yeah, doctor, one more comment. Another point to put in place the base, the alar base, is the lip marking. The lip marking. 30 years ago, during my first cases, I've been using Millar. The problem with Millar is that the lengthening of the cleft side is not enough. That is why I moved to the triangular method, because when you are doing a C-plasty, you are providing lengthening. And in my first cases, I have seen the ALA lower because I am using the ALA to correct the lip. This is a common bad outcome related to Millar, because this incision in Millar, which is cure or stripe or maybe a little cure line, is not getting enough lengthening to imitate the normal side. So they are putting the ALA lower and they are getting more lengthening. It is happening for beginners because Millar is still practicing actually, right? Of course, after Fisher, I am doing Fisher, but comment about Fisher is for other webinar, not now. But I don't like Fisher, but anyway, but that's a good comment.
I think there's too much detail that we can discuss, but I would like to stop here because there are too much things that maybe when we met next time we can also talk about this later. Thank you very much anyway.
Thank you for the opportunity, doctor. Congratulations for the nomination for the Cleft.
Thank you.
Good. Thank you very much. Thank you.
Thank you, Prof. Lo. And now I think we'll head over to the Q&A session. So I think we have two questions today from the audience that we'd like to ask Professor Rossell. The first question is a question by Dr. Lisa, and the question is, how is custom-made acrylic stent fabricated? And is the impression taken at the time of the lip repair?
Okay, excellent question. First, The process is similar to the other orthopedic that you are taking impressions. You should take an impression and create an acrylic device. This is performed by orthodontist. He is doing, okay? He's creating an impression and they are taking the mold and they creating the acrylic device. As I explained, why we use acrylic because of the cost. And this can be, it is difficult for us to create a silicone. This is a different technology. You know, we cannot create silicon stands. But the acrylic, the orthodontist can do. That is a reason. And the time, not at the time of lip repair, because the first days, all the wounds are in the inflammatory process and they're creating fluids. And if you put something there early, probably you are creating more inflammation of the wound area. That's I've seen. We don't like to put tapes after surgery, in example, because the fluids through the wound are creating a kind of more inflammation in the area. We don't want, well, I want to leave the open without tapes and putting ointment only. I like ointment. That I'm doing at the time of lip repair and nose repair is to put a package, a nasal pack. It is an important point. Why? Because we are performing a rhinoplasty. And a common complication if you don't use a pack during the first night, putting the pack after surgery, and then the next day in the morning, I'm visiting the patient and removing the pack. Because bleeding is common. There are many vessels here. I am doing a C-plasty there. If I don't put a nasal pack here, patient is bleeding. So I am using a pack here, using an ointment. I like neomycin, in example, it's good. It's a good ointment, okay, not creams, ointment, and put a pack here and removing that next day after surgery in the morning. No problem, okay? But we cannot use we cannot try to mold or taking impression at the time of the lip repair. It's not the best time. Probably few days after that. Around 5 days after surgery could be a good moment. No bleeding, it is dry. I think it's good time to take the impression. And also the contractor of the car is not starting at that time. It's 5 days could be good. That's the answer.
Okay, and our next question is from Dr. Benito, and the question is, could you share your perspective on presurgical pellet therapy for cleft width reduction for in patients with unilateral cleft lip and palate? So basically, he's asking if it's possible to reduce the burden of two surgeries into one for unilateral
Or,
cleft lip and palate patients.
and I don't have clear question, so please.
Yeah, so I think the question is it possible to do a presurgical palate therapy for patients with cleft lip and palate?
Presurgical,
Uh,
pre-
palate therapy.
palate therapy,
Yes.
presurgical palate therapy. This is a kind of I don't
I'm
have
not
clear.
exactly sure what Dr. Benito means, but I think he might the the question might be like because you're saying, we don't have to do the um orthodontic NAM, so we can
Uh-huh.
do surgical NAM instead. Is it possible to do like a pre-surgical palate treatment?
Well,
Oh, no. I said, plate therapy, pre-surgical plate therapy.
okay.
Yeah,
That our proposal is to reduce the burden of care. Okay, we are looking for the best outcome as we can do, the best outcome as we can do, with fewer interventions. We don't feel that any pre-surgical intervention is helping us in this problem. That's our point. If it is helping, probably, maybe in your experience, in your center, in your team, it is working well, and you should do that. Let me tell you, I have seen postoperative outcomes in papers. If you publish a paper, you are putting there your best outcome. Is that true? Sure. You are not putting there your worst outcome. It's the best that you have, that you are putting there. Okay? I have seen outcomes after name, after different interventions, and the outcome is not good. It's not similar. There are no similar. Probably almost, but it's not good outcome as should be. So in my understanding, they are doing too much, and the outcome is not as much as should be. That's my point. That is why I don't believe in the presurgical intervention. You can do very well without that. That's my point. I am looking after name when you see the outcome, or sometimes in conference, in meetings, I'm using orthopedics, I'm using many different, even sophisticated technologies. And when you see the post outcome, is a frontal view of the patient smiling. Sorry.
Yes.
We need science. We should be very objective. That's my answer.
Okay. Dr. Benito, would you like to clarify your question?
It will be good.
I think Benito's the meaning is want to show the like obturator to stop the communication between the oral and the nasal.
Actually,
Yeah,
can you hear me?
Excellent. Hey, Benito, please.
Yes.
Hello.
Yes,
Thank
Benito.
you very much for your great lecture. My question would be if we aim for burden reduction, could we aim for using pre-surgical treatment to reduce two surgery into one and do a single stage unilateral cleft lip palate closure?
Okay, well, but that I presented today in outcomes is a single stage. It's maybe you are talking about lip and palate in one time. Are you asking about that? Probably.
Right.
Okay. Oh, okay. Okay. Excellent. Well, anyway, let me tell you, this is a good point because we do an earlier cleft palate repair? Can we do that? Actually, probably we are accept that we are performing cleft palate repair at 9 months. Oh, probably 1 year, 9 months. Sometimes top study, they said the top study published 6 months. But the problem is that the cleft palate repair is creating an airway obstruction. It is creating an airway obstruction always. When I've seen my patient snoring after palate repair, I understand that the surgery is good. This is happening when you're doing a follow in primary repair. Patient is snoring the first, and this is improving during the days, but we are creating an obstruction. And that probably this is a congenital disease, and sometimes this is coming with other problems. I'm not feeling comfortable performing an earlier palate repair. Also, finally, this is personal perspective. We need science. If we don't have science, comparative studies, this is just a personal opinion. What I think about that. That's it only. It's my opinion, your opinion. I respect all opinions, okay? But it's difficult to get an answer without science. We should measure objectively the outcome to be compared, but we need that information. Could be, maybe what you said is okay, but we need more information. We don't have that. Enough. Information, a good level of evidence. We don't have that. I'm happy. That's my answer.
Thank you so much. Muchas gracias.
Thank you.
Thank you, Benito. And thank you, Professor Percy's well presentation for very comprehensive the primary rhinoplasty for the cleft patients. As the Professor Percy's that mentions that all the technique once as long as it's good to the patients, I believe that all the techniques should be respected and that they are all very good for those the growing children. And no matter but today I believe that Percy just want to highlight that could reduce the care burden. Yeah. So even either the pre-surgical name or surgical name. Yeah, I believe both is good to the patients. Okay. Thank you, Professor Percy, the presentation again. 2 years ago, you gave us a very good first time presentation too. So really appreciate all of your contribution to the ICC. I would like to invite all our participants tonight to have a group photo together, and I would like to announce our next ICC presentation that will be allocated 3 weeks later, and the presenter is again and again and again Professor Fayaz. Again, Professor Fayaz. This time, his topic. I check again. This time, Professor Fayaz, the topic is the primary cleft palate repair in 395 adults, the insight from the Cleft hospital experience. So looking forward to this webinar. So I will count to 3 and please show you a smile with Professor Percy, and thank you for your coming join. And welcome Jordan, Benito, and Alfredo, Kate. 1, 2, cheers. Okay, smile. Thank you very much. And thank you, Professor Percy, again. And thank you, our panelists from Philippines, Professor Dex from Indonesia, Alki, and from the National Taiwan University, Professor Huang. Thank you, Professor Low, again. Good morning and good evening. We have to conclude. Thank you very much. Thank you. Bye-bye. Bye-bye. Thank
Bye-bye.
you.
Thank you.
Thank
Thank
you,
you.
Dr. Amado Su. Hi. Thank you, Junior. Yeah.
Thank you.
Have a good
Thank
day.
you. Thank you. Have a good
Thank
day.
you.
Thank you.
Thank you. Thank you.